Hello again, everyone, and thank you for joining us today in the first of a series of webinars on diphtheria. I am Rashida Fuad Kamara, a case management officer with the WHO based in Dakar. And today we'll be having our webinar on clinical care and IPC practices for diphtheria outbreak. I would start by talking you through the code of conduct and the housekeeping rules. WHO is committed to enabling events at which everyone can participate in an inclusive, respectful, and safe environment. These events are guided by the highest ethical and professional standards, and all participants are expected to behave with integrity and respect towards all participants attending or who are involved in any WHO event. The Code of Conduct barely prevents harassment, including sexual harassment at all WHO events. Now for the housekeeping rules. We will be having interpretation in Arabic and French, as our panelists will be speaking in English. Kindly use the Q&A for questions regarding the topic and presentations. Use the chat feature for general introductions and questions. Kindly write in the chat box your name and where you're coming from. The chat could also be used by presenters to share important links, contact information, etc. If you wish to take the floor, we'll be having, I think, 5 minutes for discussions. Please raise your hand so that we can engage you. Kindly note that by participating in this meeting, whether as a panelist or participant, you are going to be recorded, and your recordings will be shared via various channels for continuous learning purposes. The session materials would be shared after the meeting. We do collect registration, participation questions and answers, chat comments, etc. for this webinar, and they will be shared by the WHO. Your individual data will be kept confidential. However, other data may be used for report, maps, communication, surveys, quality assurance, evaluation, and to inform new initiatives. The objective of today's webinar is to strengthen clinical and operational response, especially IPC capacities, for effective diphtheria outbreak management in the WHO Afro region. We, however, take note of the fact that other regions, such as EMRO, are also responding, and we are extending information to this region. For today, I will be your moderator, and this is the agenda. We will next have our opening remarks by Professor Andre Bitter, who is our incident manager for this outbreak. And then we'll have a brief EP update from Stephanie, followed by clinical care guidelines by the WHO from Jimmy. And then we'll move on to IPC, WHO operational guide by Madison. We'll then have a short break wherein you're expected to have your questions answered, or you can ask your questions. And then we'll have IPC practices in the fear response by Arifa Parker. And we'll have clinical care case management by Tari. And that would also be followed by a 5-minute discussion, and then we'll have a closing remarks. I will now hand you over to Professor Bitter for his opening remarks, and welcome again.
Thank you very much, Dr. Ashdatu. Can you hear me?
Yes.
Okay, so thank you very much. So, ladies and gentlemen, dear colleagues, dear participants from countries in WHO African regions, it is a privilege for me on behalf of the Afro Regional Director to extend a warm welcome to this webinar on the response to the diphtheria and epidemic in WHO African region, especially on enhancing clinical care and infection prevention and control practice for diphtheria response. The subjects that bring us today is of great importance because throughout history, diphtheria has been one of the most feared infectious disease in the world, causing devastating epidemics mainly affecting children. Diphtheria is a severe acute communicable disease of the upper respiratory tract caused by Corynebacterium species, primarily the toxin-producing Corynebacterium diphtheria. This vaccine-prevented disease has reappeared again in recent years, and some countries in the region have recorded epidemics. This situation can be explained by certain main factors, such as large number of children who have never received a dose of vaccine against diphtheria, notably DTP and pentavalent, or who have not completed their vaccination or received a booster dose, high promiscuity and poor hygiene and sanitation conditions. Despite significant efforts made by countries, the WHO and partners, the epidemic situation persists and is even spreading into new countries at risk, presenting the risk factors that I have just stated. Ladies and gentlemen, dear participants, concerning epidemiology, the incidence of this disease has declined significantly worldwide with the introduction of the active immunizations with diphtheria toxoid. However, diphtheria remains endemic in several regions of the world. Diphtheria has been one of the world's most feared diseases, as I was saying. For many years, diphtheria caused epidemics in Europe, Africa, India, United States, with millions of cases and thousands of deaths since 19th century. According to WHO, diphtheria is uncommon in the African region. Only 30% of the burden, the worldwide burden, were reported in the African regions. Between 2000 and 2025, Stephanie will come on details concerning epidemiology of this year. A total of almost 100,000 suspect cases of diphtheria were reported in African region, with an average of 3,005 cases per year. Over 50% of suspect cases are un or under vaccinated or without unknown immunization status. WHO support the countries of the region technically, financially, and in terms of mobilization of supplies. Technical support provides setup of incident system implementation and coordination, surveillance, laboratory, vaccination, case management, infection prevention and control, risk communication and community engagement, mobilize antibiotics and diphtheria antitoxins to treat cases. This pillar will be present as a series of webinars. So today, as Rashida too was saying, we'll start with clinical care and IPC. This is, ladies and gentlemen, dear participants, while wishing you an excellent webinar, we expect high participation from you during these question and answer sessions and hope that training can be done at all levels in your respective countries. The training models and reference document will be shared at the end of this webinar, and do not hesitate to contact WHO through the country office for training needs and reference document on the response of diphtheria epidemics. It is on this note of hope that I declare open this webinar on enhancing clinical care and IPC practice. Thank you very much for your attention.
Thank you very much, Professor Bitter. I just want to echo the fact that due to waning immunity in children who had childhood vaccine, we are seeing a resurgence in our member states, and additionally, for those that did not take the booster doses, there is an upsurge of these cases. And we all know the devastating consequences that this is causing, especially in the children and teenagers, although we also have diphtheria cases coming up in young adults. Thank you very much for this insightful introduction. I would now like to welcome Stephanie to give us the EP update. Over to you, Stephanie.
Thank you very much, Rashida. Good morning, all. Good afternoon. Next slide, please. Thank you. So just to briefly run you through the 2025 data, the current epidemiological situation, and I'll give more detail on the next slide for the cases in each country, focusing just on the Afro region, which is why you'll see some of the countries in the north of the continent are shaded in white because they're not part of Afro. But to really draw your attention to that map and looking at the districts in yellow, orange, and then red, with the highest number of suspected cases. And you can really see that band across the middle of the continent there. And just to emphasize, I know that currently the map stops at Chad, but to note there are many cases in Sudan, in Somalia, in Yemen, but also other neighboring countries. So we can really see that surge in cases and the movement of cases across the continent. Just to highlight the over 21,000 cases that have been reported so far in 2025, and quite a high case fatality rate of roughly 6%, with Nigeria reporting the highest number of cases, although noting also the incredibly large population, but also the high case fatality, especially in Guinea, which is reporting a case fatality rate of about 23%. Next slide, please. So of the 8 countries in the African region that are currently reporting cases, these were the latest numbers that we had available as of the beginning of this week. So you can see that Nigeria is reporting over 12,000 cases, Niger over 2,000, and over 1,000 in Mauritania, and over 4,500 cases in Chad. I wanted to draw your attention to the very few laboratory confirmed cases and the challenges there that countries are facing. Just 5.5% of cases are laboratory confirmed, although many more cases have been epi-linked or are clinically compatible, which we'll discuss more today. As I've said, case fatality rate is high. It is variable across countries, but we are seeing much higher than we would expect to see. Across countries, there's also quite widespread community transmission, with some countries reporting between 50 and 80% of regions or provinces affected and reporting cases in recent weeks, just really highlighting the scale of transmission that we're currently facing. Next slide, please. So just to look over time this year, and we can see on the top left chart in the gray bars, the number of cases reported each week and how that's really increased in recent weeks. I don't want you to pay too much attention to the last few weeks, week 45, 46, or 47. We know there's quite large delays in reporting from some countries, and so this just takes time for these cases to catch up. But we can see that has been quite a large spike in cases. And the graph on the bottom right in the colors shows the makeup of countries reporting cases each week. So we can see in the green, Nigeria is reporting the majority of cases, although earlier in the year, Chad was reporting the most cases. And in recent weeks, we can see surges in Mauritania in the pink, in Mali, and Chad and Niger as well. Next slide, please. Again, to look in a bit more detail around case fatality, on the x-axis along the bottom, the horizontal axis, we can see the total number of cases. So as cases increase, and this is on a log scale, and on the y-axis are the case fatality rate. So countries higher up the graph have a higher case fatality rate. Countries with larger circles have more cases and more deaths that have been reported. The red dotted line shows our 5% case fatality rate threshold, where we like to keep deaths below. And so we can see that most countries are reporting above this threshold, which is obviously cause for concern, and why strengthening clinical management that we're discussing today is so important. Next slide, please. Now, as Rashida noted just before I started talking, pardon me, we're really conscious of waning immunity, and the majority of cases we're seeing are among people aged 5 to 14 years, so children and younger adolescents, but really highlighting this is not just COVID that's, impacted on immunization. This is longer term. Challenges with implementing routine immunization, and the second most affected population, about 30% of cases, are over 15 years. So we are looking at long-term gaps in immunization. We don't have good data on vaccine coverage, but our understanding is that generally most cases are not vaccinated or are only partially vaccinated. And as is often the case with diphtheria, there is a skew towards females. About 64% of cases are women. Next slide, please. So just to wrap up and give some thoughts as we start the seminar, I've mentioned the challenges around lab confirmation, but also case definitions, and I think we'll get more clarity on that today. But again, as Prof. Beta said, we're always available. Please do reach out, and guidelines are routinely published on the website that are accessible for everyone. I know today we'll discuss the need around antitoxin, around vaccines, case management, kits, so the general support that is needed to strengthen clinical management. But generally, both among governments and in the population level, there is a lack of awareness, and further advocacy is needed to highlight the current scale of the outbreaks, particularly in these 8 countries, and the risks to neighboring countries or for further spread. Data has been challenging to collect and report, and so further strengthening these mechanisms would also help our identification of hotspots and targeting of interventions to better respond. And part of that response would also include vaccination and where we can establish outbreak response campaigns. So I'll leave it there, but we'll be available online. Thank you so much. Have a good webinar.
Thank you very much, Stephanie, for throwing light on the epi pattern in the region. You've definitely shown us what is happening in our countries. And for participants on the call, please note that we are seeing an evolution of this outbreak, with 8 countries now reporting cases in our region. And the cases are increasing at 21,000. Without further ado, may I welcome Jamie to talk us through the clinical care recommendations by the WHO.
Thanks very much. So I am going to talk through the outline of the 2024 WHO guidance. The guidelines I will talk about are based on the GRADE standard for recommendations, and they complement other WHO guidance, particularly from the Africa Regional Office. This is what I'm talking about, and you can access it online in an online format or through a PDF which you can download. And this is perhaps all you need to know. There are 3 recommendations in this guideline, and the reason that this is a small guideline is the guideline development group focused on the things they felt would reduce the mortality. You have seen from what Stephanie has presented, the mortality is unacceptably high, and it is difficult to provide high quality care in many of the regions in which we have the most patients. What will make a difference? These things will make a difference. Getting the right antibiotics to the right people. Getting diphtheria antitoxin to the right people. And getting the right dose of each to the right people. That seems easier than it is, but these guidelines are to try and help improve the uptake. Antibiotics and diphtheria antitoxin are not exclusive. They're given to the same people, and I'll describe that in a moment. Firstly, then, what antibiotics should we be giving? Stephanie already described the problems based on laboratory confirmation and antibacterial sensitivity testing, that we don't know necessarily what we are dealing with in terms of resistance patterns. Our guideline development group looked at this and noticed that there was a lack of evidence in many places, but there was an increasing penicillin resistance amongst Corynebacterium, the causative species, genus and species of diphtheria, but less resistance to macrolides. And macrolides here would be erythromycin and azithromycin. The group said quite rightly that antimicrobial susceptibility testing is vital to really know. But the choice of the antibiotic and the choice of the macrolide will be dependent on what you have available to you. What underpinned this recommendation? Well, one randomized control trial of, as you think, a very small number of people. It did not show a difference in mortality, and there was some uncertainty around disease outcomes, but it was the best available. And the group noticed that macrolides, particularly azithromycin, would be much easier to administer orally than penicillins, which might be of increased frequency. Secondly, there is no recommendation about oral versus intravenous. Oral antibiotics should be used where at all possible. There may be considerations where there is difficulty swallowing, particularly in diphtheria, that might necessitate other routes of administration. But for most patients, most of the time, an oral macrolide would be the first choice, unless you know other resistance patterns from your region. If you know, for example, that the resistance rates to penicillin in your region are very low, then penicillin is a perfectly reasonable choice for antibiotic. I'm going to move on now to diphtheria antitoxin. Now, this was the recipient of the Nobel Prize for Medicine in, I think, 1900. It's been around for a very long time. It comes from horses, primarily, which are inoculated with diphtheria antigens and produce immunoglobulin. And that immunoglobulin is filtered and produced to give to patients. It's been given for over 125 years, and it was responsible for a reduction in mortality of more than 30% in that time. It's still considered the main part of treating people with diphtheria, and I think it's underused. It's underused because it can be complicated. It's underused because the availability is difficult. It may be expensive, and there is a global shortfall compared to need. And it's underused because people are not necessarily comfortable. It's not a routine part of our medicine practice. As a result of it being a long-standing medication, the evidence behind dosing is very uncertain, and our guideline panel noticed this. We do presume that there is no comparative evidence for dosing regimes, but higher doses are theoretically better where you think there is higher doses of diphtheria toxin, the thing that kills people. That would be in severe or late disease. So the regimens, the severity here goes from 2 vials of 10,000 units or 20,000 international units where you have limited laryngitis or pharyngitis and you have early disease presentation to a facility. And you'll see that if you have later presentation, the guidelines are for 40,000 international units. And if there are particularly good reasons to think that there is severe disease, and that includes relatively later presentation, respiratory distress, shock, or diffuse swelling of the neck, for example, bull neck, then higher doses are suggested. You'll see that 48 hours is quite an early time point, particularly in humanitarian settings, to get people into facilities. So it's quite a high bar, but we know that early treatment should be the goal because early treatment and less severe disease has much better outcomes. One of the other reasons that antitoxin is probably not given is that it's complicated to administer. And there have been different strategies. I've told you how diphtheria antitoxin is manufactured from other animals. And one of the problems, therefore, of any immunoglobulin is that it can cause an allergic reaction. So we know that as a baseline, whenever you give antitoxin for anything, for snake bite, for diphtheria, for other indications, there is a risk of allergic reaction. And you therefore need monitoring equipment. You need emergency medicines, including epinephrine, adrenaline, salbutamol, antihistamines, corticosteroids, and other medications that support someone having an allergic reaction, and the people necessary to be able to deal with those allergic reactions. That said, they occur in a lot less than 3% of individuals who have antitoxin, and the outcomes, for example, where it's given in Cox's Bazar, Bangladesh, are very good, even where there's an allergic reaction. Historically, therefore, we've used sensitivity testing, firstly to identify people who might have allergic reactions, and secondly to desensitize people who do have allergic reactions. Our guideline panel looked at this to see if there was good evidence to do it. Why would you do it? Well, if the prediction were good, if you could give diphtheria antitoxin to more people as a result, then it would be beneficial. If it's complicated, if it's a poor predictor, then it would be a problem in that it would generate more hurdles before the patient got medication that is known to improve their outcomes. On balance, the guideline development group noticed that sensitivity testing is complex. It's time consuming, it has a poor predictive value for adverse reactions. And as I said, adverse reactions occur both at low rates and have good outcomes where they occur. The biggest problem for a patient who needs DAT is not getting DAT, not getting the diphtheria antitoxin. On that basis, the guideline development panel made a strong recommendation against sensitivity testing. So they said, anyone that requires clinically diphtheria antitoxin should get it. You should not wait to do sensitivity testing, but you should have everything you need to deal with allergic reactions. And so hopefully, if that's implemented, if we're able to sensitize healthcare workers to the needs to deal with patients who have a problem, more patients will get diphtheria antitoxin, more patients will benefit, and will reduce mortality. These are the recommendations that I showed you with just the extra remarks. Just to remind you that the diphtheria antitoxin, the dose is the same for children and adults, but according to the severity of disease, there should only be one dose, because if you give more than one dose, then you can have hypersensitivity. For antibiotics, macrolides are preferred unless you know that penicillin sensitivity is particularly good. That is, there is no penicillin resistance, in which case penicillins are fine. There are a number of WHO resources, including the clinical management guidelines, but also how to prepare DAT, how to administer the diphtheria antitoxin, and the safety protocols you should have in place where you do give it. Those are all available online. What are the future directions? I've said that the guidelines are relatively limited in their scope. They're looking at the high value items. Over the next year, we intend to ask our guideline development panel to look at the wider use of antibiotics, for example, in breaking chains of transmission, on which we do not currently have any WHO recommendations. We'll come back when we have the results of that, but for now, thank you.
All right, thank you very much, Jamie. We have listened to you on the WHO's recommendations, and we take note of the fact that alongside antibiotics, DAT should be used concurrently. We also take note of the fact that WHO recommends macrolides over the penicillins, and looking at the areas where we're coming from, if erythromycin is available, they could be considered, and also azithromycin. And again, most importantly, when we are using that, the sensitivity testing is not usually recommended. However, we should avail ourselves with all the antihistamines, adrenaline, whatever it is, so that if there is any side effect, this could be managed timely. Thank you very much for the information that you have shared. I hope our colleagues, our case managers, our frontline responders will take note as we try to reduce the mortality, which is currently at 6%, CFR, sorry, at 6% in our region. All right, so we would now move on to Madison to share with us the IPC recommendations from the WHO.
Thank you so much, Rashida. Can you just confirm that you're able to hear and see my presentation? Okay, sounds good. Okay, so WHO operational guides and tools on diphtheria, which was published early last year. And it looks like this. So this is a published document, and just to make sure that everybody has this available to them, the slides that I'm about to present are also an open WHO course on infection prevention and control for diphtheria. And the operational guide, I can drop the link in. I hope that we have a chat or Q&A function that I can share the link. For this module, we're going to talk about safe care for patients with diphtheria in the healthcare setting, standard and transmission-based precautions that are applicable, and measures for isolation in the home care setting and for those who are discharged because they no longer require clinical care in hospital to maintain the infection prevention control measures in the home environment. So for transmission, the primary risk factor that we're worried about in infection prevention control is the respiratory droplets that are transmitted from patients with respiratory diphtheria. There is also a risk from direct contact with the infected skin lesions for cutaneous diphtheria, as well as articles of clothing and other items that are soiled with the discharges from the lesions. Usually an incubation period of about 2 to 5 days. So this is the period after being exposed to respiratory droplets or cutaneous diphtheria lesions before you will experience symptoms in another person. It can be longer, can be within a range of 1 to 10 days. So just for importance, why we look at that type of information is so that we can determine which infections that resulted from exposure to diphtheria resulted in healthcare-associated infections. So these are infections which may have occurred in the healthcare environment rather than in the community environment. And these are what we are trying to prevent with infection prevention and control measures. Within the operational guide for diphtheria, there is guidance on how to detect healthcare-associated infections, and of course, all the measures that are needed to respond to cases of diphtheria in healthcare settings and during outbreaks. So the key measures up front, if you take nothing else away from today for infection prevention and control pieces, is that we would advise that all health and care workers are vaccinated against diphtheria, including relevant booster doses. We would advise that all patients with diphtheria be isolated and preferably for respiratory diphtheria in single well-ventilated patient rooms. If single patient rooms are limited, we don't recommend cohorting of suspect patients. If they are confirmed cases, that's a possibility, but for suspected cases, because there is a very high risk that it is a different form of respiratory infection, to avoid cross-transmission of those infections, we would recommend single rooms. We would recommend using droplet precautions for respiratory diphtheria, which is the use of a medical mask and additional personal protective equipment based on a risk assessment. And we would recommend using contact precautions for cutaneous diphtheria when performing care that involves direct contact with the patient. And of course, additional PPE based on risk of splashes and other types of exposures within the care environment. We would also recommend that visitors or caregivers that are involved in patient care should also wear the appropriate PPE to the transmission-based precautions when at least 1 meter distance cannot be maintained between them and the patient. And they will need to be instructed on the donning and doffing of the personal protective equipment and the procedures for hand hygiene as relevant to the facility. Screening is a very important piece that we emphasize in the context of diphtheria so that you can recognize the cases early. There's quite a lot of information about setting up screening practices within healthcare facilities, within the operational guide, and within our syndromic screening tool from WHO, which I'm going to get into in just a second. And the idea here is that you are recognizing the case, you are managing them early, you are limiting the possibility of healthcare-associated infection transmission within the facility. So this is some additional pieces around the importance of maintaining a clean and safe screening area. It is a place where you are identifying cases that may have infectious risk within the healthcare facility. And we would advise that as part of this process, that not only diphtheria is screened for. I'm just going to go forward to our syndromic screening tool and to note that there is a range of infections that can transmit as healthcare associated infections within the patient care area. And a lot of them can be recognized by signs and symptoms during your initial screening and triage steps. So cases that come in with lesions, which could be diphtheria, could be a wide variety of other infections, respiratory symptoms, which could be diphtheria, could be a wide variety of other respiratory infections. And for patients who come in with diarrhea. There is a tool called the Syndromic Screening for Infection Prevention and Control during Public Health Emergencies. It's available on our website that provides some resources on how to go about this. The idea is to ensure that patients with obvious signs and symptoms of a potential infection are managed appropriately and they're not grouped together or sitting near each other in a waiting room for any long period of time. The idea is to manage them appropriately, limit your risk, especially in that initial gathering point of waiting areas or clinical assessment spaces, emergency departments, et cetera, and to ensure that you are placing the appropriate infection prevention control precautions as soon as possible. Isolation is something that is recommended in the context of cases with diphtheria. And the idea is that we are isolating symptomatic patients from others to reduce the onward risk of transmission. And the initial step for a patient with diphtheria is to offer the patient a medical mask to reduce the onward transmission risk from respiratory diphtheria. There also may be a use for covering the lesions for cutaneous diphtheria, but for now, the most important part that we advise is that providing a medical mask to patients with respiratory diphtheria and moving them from common areas into a single room. Standard precautions, I'm just going to talk about very briefly, and these are the minimum prevention measures to be used for all patients, irrespective of whether or not they have a suspected or confirmed infection. And there is quite a lot contained within standard precautions, but if all of these standard precautions are in place and they are practiced for all patients in all instances, you are limiting your risk of transmission of diphtheria and of many other infections within the healthcare space very effectively. And if all of these standard precautions are in place at all times, the additional precautions that are needed for diphtheria are only value added. The important piece is to make sure that there is a standard of infection prevention control within your facility that is maintaining all of these standard precautions. Transmission-based precautions are the addition onto standard precautions, and that is where you're using a single room, or if you are cohorting, that you have adequate space between beds, using appropriate ventilation standards, using separate toileting where needed. The idea is to inform all persons who are involved in the care of the patient that these precautions are in place. And the idea is also to do the risk assessment for that patient and apply it universally. So when persons are caring for the patient, they are not having to make the choice of appropriate PPE to use for that patient. This is something that is put right in the signage on the door and applied universally, no matter who is entering the space. Dedicated equipment and additional cleaning and disinfection protocols may also apply, as they do in the context of diphtheria. We would advise for diphtheria the single patient room, but when single patient rooms are not available, cohorting patients with confirmed respiratory diphtheria separately from patients with cutaneous diphtheria may be performed with at least 1 meter distance between the patients and drawing the curtains between the patient spaces to create separate spaces. And the separate spaces is very important because we would not like to use the same personal protective equipment when moving from patient to patient. We would not like to use the same cloths that are being used for cleaning of the patient environment when transitioning from one patient space to another. A patient should wear a medical mask and cover lesions potentially until a room is available, and whenever being transported or outside of their patient room. In a situation where single patient rooms are not available or where the bed occupancy is expected to reach 100% or more, there are some options to increase the occupancy rate within a healthcare facility by assessing the existing space, determine if it can be modified to make the additional space for patient care, to establish safe referral and transfer systems to partnered healthcare facilities that can apply transmission-based precautions appropriately. And during intense surges or community outbreaks, consider establishing or repurposing existing community infrastructure or isolation facilities to enable that additional space to perform patient care safely. Natural or mechanical ventilation should be assured because this is a respiratory transmitted infection and is mostly transmitted, as far as we're aware, in large droplets. But because there is the ambient risk of aerosol transmission with all respiratory infections, a ventilation rate should be assured in all common areas, the waiting room, triage, and on the wards. And WHO recommends a minimum ventilation flow rate of 60 liters per second per patient will need to be evaluated by a ventilation specialist. And for severe and critical wards, ensuring 160 liters per second ventilation rates is very similar to what is used in operating rooms. If aerosol generating procedures are performed, which may be the case for patients with severe respiratory diphtheria, and negative pressure rooms are advised. So droplet precautions for patients with suspected or confirmed respiratory diphtheria. This is the medical mask. Use a risk assessment if there is anticipated splashes, sprays, or otherwise contamination with the secretions and excretions from the patient in the care area. Then using eye protection, gown and gloves is the recommended risk assessment. Hand hygiene should always be performed as per the WHO 5 moments for hand hygiene. Contact precautions for cutaneous diphtheria, and with the same risk assessment pieces, and this is using a gown and gloves. During care of patients with diphtheria, we would always advise refraining from touching the eyes, nose, or mouth with contaminated gloves or with ungloved hands. We touch our faces so many times during the day without being consciously aware of this. And so ensuring that well PPE is on or well in the patient room, that we are constantly thinking about trying to avoid bringing our hands to the portals of entry in our face, in our eyes, nose, and mouth. Using disposable or dedicated patient care equipment, certainly a very useful thing to do for patients with diphtheria. When it's not possible to dedicate the equipment to a single patient, cleaning and disinfecting the equipment with an approved disinfectant before use on other patients is always advised as part of standard precautions. Avoiding the unnecessary movement of suspected or confirmed patients allows us to contain contamination to a single space, and providing source control measures like the medical mask or covering the lesions or wounds if the patient needs to be out of their room. After exiting the room, of course, hand hygiene, removing PPE. This also applies if you have a dedicated patient space with a curtain separation, trying to contain all of the contamination that a health worker may be exposed to within that patient space, and not allowing contamination to spread to the larger healthcare environment. For patients and family, we are always trying to ensure that the number of people who are coming to visit a patient and who may spread additional contamination risk to other spaces within the facility is limited. So identifying a designated family member or caregiver, especially for children, to limit the number of people who are coming in and out, and providing education to that person to be able to make the appropriate decisions on personal protective equipment and know when and how to perform hand hygiene within the patient space is very important. For the environment, we would advise at least once a day cleaning and disinfection, and more frequently if there is any additional contamination or soiling within the patient space. The space must first be cleaned with soap and water using a clean cloth, and that should happen for every patient space. An approved disinfectant for healthcare settings. For diphtheria, it's fairly susceptible to disinfectant products within the care environment. We know that a 0.1% chlorine solution is fairly effective, as is a 70% alcohol. Most disinfectants that are rated for use in a healthcare environment will be effective against diphtheria. We would always advise following manufacturer's instructions for preparation and use, including the contact time within the patient care environment, especially because we are, of course, trying to get rid of all other pathogens that may be residing on surfaces beyond diphtheria. Appropriate waste management disposal of PPE and cleaning products as they need to be disposed of, cloths, etc., must occur according to local regulations, because this would be considered infectious waste. Is a tool that is available on the WHO website on surface cleaning and disinfecting in patient care areas. And the most important piece here is that cloths that are used in one patient care area are not brought to other patient care areas, potentially spreading excess contamination. After use of a cloth in a single patient care area, it must go to either laundry, or if it is a disposable cloth, is disposed of as infectious waste. Duration of transmission-based precautions for patients with diphtheria. is somewhat unknown at the moment. And this is something that, as Jamie mentioned at the end of his presentation, will be something that can be refined with the antibiotic therapy clinical guidance. During an outbreak where there is limited or no laboratory testing and there is limited isolation capacity, we would recommend that even in absence of symptoms, that transmission-based precautions be maintained for the duration of hospitalization, and that patients should remain in isolation at home until they've completed their antimicrobial therapies and have been symptom-free for at least 24 hours. After 5 days of appropriate treatment, even where there is no a resolution of symptoms at that time, discontinuation of home isolation can be considered with the support of a clinician or an infection prevention control specialist. At home, we advise keeping distance, ventilation, open windows, hand washing, using respiratory hygiene like coughing and sneezing into the elbow or use of a medical mask. And we would advise that other family members or persons within the household of a patient with diphtheria get vaccinated as soon as they can, with the hope that we can avoid additional onward transmission. For health and care worker exposures, there is some guidance on what is an occupational exposure and what should be expected for health and care workers. There is quite a lot of information that's available on this in our operational guide, and for anybody who's managing occupational health and safety as part of a diphtheria response, we would advise that they take a look at that. And that's all from me. Thank you.
Excellent. Thank you very much, Madison, for delivering that very brilliant presentation on IPC. So we take note of the fact that alongside our standard precautions, there is a need for us to look at what we apply for respiratory as well as cutaneous diphtheria. So we should apply or use our mask when we suspect the patient for respiratory, and if there is any skin lesion implying that that patient could have cutaneous diphtheria, we need to apply our contact with precautions. And the most important thing is that we must isolate a suspected or confirmed case immediately. So these are things that we do take into consideration, and also for the participants online, let us adhere to these guiding principles to mitigate transmission. We would be sharing these slides, the ones that we have received from IPC and also clinical care, and kindly look at the WHO recommendations, the links that were shared or that I've shared with you, so that you'll be able to apply them. At this point, I think we're going to have a break to have discussions. If there are any biting issues or questions or comments that we want to make, please raise your hand. In the interim, we'll also be looking at the Q&A chat box to see if there are any questions for the panelists. Amarachi, if there's any hand raised, please let us know. Meanwhile, let me go to the Q&A. Okay, so the first question will be directed to you, Madison. It reads, what is the minimum PPE we need in that case? Not sure what that means, but I think they're asking about the minimum PPE that we should use when we are managing suspected or confirmed cases. The second one is also for you. Do healthcare workers need to wear masks when they are transferring patients to isolation room? And then I don't know if we have Jamie still on the call. Is there a proof that diphtheria is resisting antibiotics? Over to you, panelists, for your responses.
Thanks so much, Rashida. The minimum PPE is going to be dependent on what symptoms that you recognize in the patient as part of your screening process. But I would advise in general that a medical mask is probably your minimum. For a patient with respiratory diphtheria is the higher risk because there's a transmission mode that has the outbound droplets from the patient's throat. So you should, as part of ensuring that you have the appropriate PPE, no matter what situation that you come across, have eye protection, either goggles or face shield, fluid-resistant gowns or aprons, and medical masks, respirators available within the healthcare facility. So all of the PPE that you may need for any situation should be available, present, used according to risk assessment. But when caring for a suspected case of diphtheria, it's going to depend on whether you recognize it to be respiratory or cutaneous. Apologies, the question on health and care workers again, Rashida, too.
Yeah. So, do healthcare workers need to wear masks when they are transferring patient to isolation room?
Yes. So droplet precautions for respiratory diphtheria would apply both to using a medical mask for source control in the patient, which limits the ability of them to produce droplets within the patient environment, and also for health and care workers that are performing close care. And transporting of the patient would be very close care. So yes, over from me.
Thank you, Madison. Jimmy, can we hear your response, please?
Sure. The quick answer is yes, there is antimicrobial resistance in many species of Corynebacterium, but also in the diphtheriae and toxin-producing forms. I have added a link in the chat to a more recent population genomics and AMR survey. The difficulty is that none of these things are systematically looked at in terms, because we've, as Stephanie already suggested, it's a small minority of people who have laboratory sampling, but we can detect, particularly in that case series of 163 clinical isolates, a penicillin resistance of approximately 17%, compared with erythromycin of approximately 2.5%. So I'm not saying that reflects your local situation. I don't know. But our panel did say that given that penicillin resistance is known, it's probably, unless you know better, macrolides, which would be the preferred first option. Over.
All right, thank you. So participants, I encourage you to sit tight because we are going to see how these rules of thumb are being applied in our settings. We're going to look at clinical presentations as well as IPC practices in our various settings. May I now welcome Dr. Arifa Parker to talk us through IPC practices in South Africa. Over to you, Dr. Parker.
Good afternoon, everyone. Thank you to the WHO team for the opportunity to provide reflection from our experience of managing diphtheria cases, and I'm going to be focusing on what we did from an IPC and a staff management perspective. My first exposure to diphtheria was in 2017. So those who may not know is that the diphtheria vaccine was introduced into the South African vaccination program in the 1950s. And we've had many decades without diphtheria. And prior to 2024, there'd been a handful of isolated and sporadic outbreaks over the 70 years. So my first encounter was an outbreak in 2017, where the index case was a 10-year-old girl who came from a densely populated informal settlement, and she had an unknown vaccination history. These are actually pictures from her sibling that I was part of management of. So the index case attended a local school. There were 4 siblings with either unknown or incomplete vaccination history. And the index patient presented with a severe sore throat, a pseudomembrane, and a bull neck. She was actually admitted with a threatened airway or airway obstruction requiring urgent tracheostomy. And during the procedure, the membrane was then noticed. And this was done by one of the ENT surgeon. Sadly, at the time, because we hadn't had any cases, there was no antitoxin in our province, and we did try to get from outside of Cape Town, but it arrived too late for that patient, who ended up developing acute kidney injury, and despite dialysis, the patient demised. And these are just pictures of what diphtheria looked like. So this was the sibling who was fortunately able to be managed appropriately with antibiotics and antitoxin and recovered well. So reflecting back, this outbreak required a massive coordinated IPC, occupational health, and public health response. We over 70 healthcare workers ended up being exposed, required screening, swabbing, and post-exposure prophylaxis with antibiotics and vaccination. And the lesson we learned at the time is that we needed to be prepared, and we could avoid this unnecessary risk of healthcare associated transmission and the need for prophylaxis by having better infection control systems in place. So the fallout from diphtheria can actually extend beyond the individual cases. And a sore throat is quite common, so these can be quite difficult to manage, especially when antitoxin is costly and maybe in short supply. So these are 2 cases from the community screening. Patient 1, the picture on the top, had a sore throat with this white lesion, which ended up not being diphtheria. It was a patient who had ended up having TB and candida and responded to fluconazole. The second picture, and you can see the red throat in the image without a membrane, was actually a neighbor of the index case who was targeted in the public health response and was vaccinated, but the patient didn't take the antibiotics, and her swab was actually positive for diphtheria, and she was managed for that. And then the third image is actually from the same ENT surgeon who did the procedure and or the tracheostomy, and 5 days later, after starting his antibiotics, which was, I think, penicillin at the time, he developed the sore throat, and you may be able to see these white spots at the back of his throat. Fortunately, this was not diphtheria. The gram stain showed yeast, and it was actually oral candida, likely from the antibiotic prophylaxis, and it settled well with antifungal amphotericin B lozenges. So we learned that we needed to be prepared. There can be a lot of panic, and we can avoid unnecessary healthcare transmission with proper systems. So fast forward to 2025, where we are facing a global reemergence of this ancient, devastating infection. Diphtheria is now endemic in the Western Cape, and we've had over 100 confirmed cases. And these are images from the first case were presented to my hospital in late 2024. And this patient was released from a prison correctional facility. On the same day of presentation, we had the sore throat. You can see the marked edematous airway, and it clearly looks like diphtheria. We learned from our previous experience, and what we ended up doing was bypassing the busy emergency area, and he was immediately transferred with paramedics wearing the appropriate PPE directly into a monitored isolation room so that he could receive his antitoxin. And you can see the second picture after antibiotics. You can see the membrane getting smaller, and he made a full recovery. And from this case, there was actually no staff exposures without PPE in our hospital requiring any antibiotics because there was a protocol in place. However, we did do healthcare worker vaccination boosters at our facility, and it's actually part of policy for our province to ensure that at least high-risk staff are protected. So the case also showed the complexity of movement in managing cases of diphtheria. So the patient was released from prison, and so the prison needed a massive coordinated public health response and experienced successive outbreaks, which needed to be managed. And then the patient took public transport to a family member's home, and then hitchhiked to a rural area where he visited a GP and a hospital. And it is not surprising that we are seeing ongoing community transmission. So we in the Western Cape or Cape Town need to really optimize our vaccination coverage, particularly our adolescent boosters, as well as what we are currently doing, which is a pragmatic approach to targeted adult boosting. So this is a snapshot of our IPC approach. The first rule of any emergency is to protect yourself so that you can protect others. So stay calm, protect yourself. The most important thing you need to do when you suspect a case is to take it seriously. Put on your PPE, remove the risk to other vulnerable patients and staff by having the patient move to isolation. It is very important that you identify the space for isolation ahead of time. So we use a single room in our high care setting, which is separate to the emergency unit. We have had cases where we didn't have beds, and then we used an isolation room in the emergency unit. And if you have a difficulty with that, another option is to use a space in the corner with dividers. But we tried not to do that, but sometimes dependent on urgency and space availability, one needs to improvise. Remember that when you isolate a patient, you must have a plan for de-isolation. And so our protocol was, and it's also provincial and national policy now, is that if the patient has had a good response to antibiotics, we de-isolate at day 7. So we also view antibiotics, we also used azithromycin as an important IPC measure because we expect a rapid decline in the organism load within the first 24 to 48 hours. But evidence from a systematic review does show that there can be clearance by day 4 to 6. So that's why we de-isolate at day 7. We also did initially do swabs for clearance at day 3 and day 5. and we have not had a single follow-up swab positive, which is actually reassuring, and that's why we reduced our isolation to 7 days. What PPE did we wear? We definitely wore a mask, eye protection. We also used a gown and gloves for our patients. Because we also work in a high TB burden area, we do recommend that an N95 mask is worn for all undifferentiated cases. I think for diphtheria, the recommendation of a medical mask is appropriate, but we do advise in our setting that we also wear an N95 mask, especially if there's a potential risk of aerosolization or if the ventilation is possibly not adequate. And then in terms of IPC components of care, there are multiple components. So aside from being prepared, it is very important that there is education and awareness around recognition of diphtheria. So sore throat with a membrane or history of contact. Without recognizing diphtheria, you won't be able to mitigate that transmission risk. So once you suspect diphtheria, the measures that I've mentioned, patient placement in an isolation room, prompt initiation of antibiotics is very important, because the sooner you start antibiotics, the sooner the organism is cleared and the less transmission risk there will be. And we also used, aside from emerging resistance, we also used azithromycin because it can be given once a day. So that is an advantage to potentially limit transmission risk to staff. I mentioned the vaccination to ensure that your healthcare workers are vaccinated. They do still need to wear PPE despite vaccination. And Madison has gone through all the IPC precautions. So it's not just about wearing PPE, there are other components of prevention that are equally, or if not more crucial. So despite protocols in place, exposures can still happen. One example was when one of our anesthetists had come down to do an emergency to assist with the airway in a patient who had a difficult airway. And the airway was so swollen, he had to do an emergency tracheostomy. And he said there just wasn't time to do PPE. I think then it's very important to then stay calm, because there are options to prevent transmission in this scenario. So in our setting, we prescribe a 7-day course of azithromycin. We do swabs pre and post, or at the end of treatment, as Madison mentioned. And, you know, where the evidence base is not that clear is, could we use shorter doses, durations of azithromycin? Because unlike penicillin, azithromycin has a longer elimination half-life of about 60 hours. So we could potentially get away with a shorter dose, but more evidence around this is needed. If the staff hasn't had a vaccine, you can vaccinate. If they've had a booster, it's probably not necessary. And then just remind you that if a staff member had worn PPE, there's no need for antibiotic prophylaxis, even if the patient was, or if the staff member was not vaccinated. We always tell our staff to monitor, or we monitor for symptoms, as they may need antitoxin or extended duration of antibiotics. So to end off, we've definitely learned many lessons from our management of diphtheria cases. The differential can be broad, which can create a problem, especially if there's delayed recognition, with increased risk of transmission, as well as delay in antitoxin, which can cause harm for the individual patient. we find that there is diagnostic delays if we want lab confirmation. So clinical responding to on the basis of clinical suspicion is extremely important. We don't wait for confirmation. In our setting, I just want to take this opportunity to thank the World Health Organization for assisting us with life-saving antitoxin when we really needed it, and it has definitely saved countless of lives in 2024 and 2025. And then IPC measures, extremely crucial. I just want to say that in our setting, we have swabbed or screened countless numbers of healthcare workers over the years, and we have fortunately thus far not had a positive in any healthcare workers. So that is quite reassuring. It shows that if you use preventative measures such as PPE, appropriate isolation, managing of the patient, that we can prevent transmission to healthcare workers. And then vaccination is definitely key, and we do need to improve our vaccination coverage. Thank you so much. That's it from my side. Thanks.
Thank you very much, Dr. Parker, for that very, very brilliant, interesting presentation. And congratulations that you have not experienced any healthcare worker infection. That is very key. And I think it gives us all hope for us, the first line responders, those of us that are practicing, that are managing these patients. If we do adhere to all of the IPC precautions or the measures that have been shared with us, I am sure we'll be able to keep ourselves safe and also reduce some transmission and, in fact, reduce mortality. Excellent. Thank you very much. I also take note of the fact that in some states now, we are seeing endemicity of diphtheria. And that is very sad because diphtheria is supposed to be a vaccine-preventable disease. And according to the WHO, the recommendation is that in infant at as early as 6 weeks of life of age, children should start receiving their vaccines 4 weeks apart, and then additional booster doses in between the ages of 2 to 3, and then we should also have between 4 to 7, and then in the teenage years 9 to 15. So it is such a big problem that we are now seeing diphtheria re-emerging, and it is becoming endemic in our region. However, let me also thank you once again, and we are sure to adhere to what you have shared with us. Thank you very much. So we'll now have Dr. Tari to take us through clinical care. Yeah, thank you.
Okay, thank you so much, and thank you to the WHO for inviting me, and also I cannot reiterate how grateful we are in South Africa for the WHO assisting us in our cases that we've had. So let's get right into it. I'm going to be talking about some clinical cases and some management considerations, a practical guide to it, what we've done in South Africa. And this is just a quick case definition of when you suspect diphtheria, and I want to make it quite simple, and I want people and colleagues to remember that classic diphtheria is essentially an upper respiratory tract illness where a patient has a sore throat, a low-grade fever, and an adherent membrane, also known as a pseudomembrane, which can be of the nose, the pharynx, the tonsils, or the larynx. There are other options of confirmed cases, but that takes into account the laboratory criteria. So for me, the most important is understanding what is the clinical aspect of these patients. Right. This is a case that we dealt with a couple of years ago, where a patient essentially presented with an upper respiratory tract illness, and one can see over here that there's this white membrane. It's bilateral. You can see there's this grayish area over here. And furthermore, one can see that the tonsillar region as well as the uvula are markedly edematous. And we'll come back to this gentleman a little bit later. I want to show colleagues what are potential differentials to a pseudomembrane. And initially, when we got shown this patient, we thought, oh goodness, there's a pseudomembrane over here. It's a bit unusual. It's very, very white and almost looks like there's a follicular tonsillitis over here. And when our ENT colleagues kindly came to review the patient, they stuck a needle in this area and actually saw that it was just pus coming out of the area, which was suggestive of Quincy's. And this patient actually grew a group A streptococcus. And here is another case that we recently had where a patient again had this membrane sitting over the tonsillar region. But what's rather unusual is that there's a membrane which is sitting over the tongue area over here. And we decided not to treat this as diphtheria. We didn't have any results at that point in time. And we did some other blood tests because the history was also quite prolonged. It was a number of weeks. And we actually noticed that this patient had secondary syphilis. So one can see that after 5 days of starting a single dose of benzathine penicillin IMI, one could see that already this membrane over the tongue as well as over the tonsillar area was starting to disappear. And by 7 days, it's almost completely gone. So this is a case of syphilis. This was an interesting case that we dealt with. Young lady presented again with sore throat, fever, coughing, etc., but actually very well looking. But one can see that there's again bilateral disease, whitish membrane over here, the uvula is edematous, there's a grayish area over here. And this patient threw us off a bit. We treated her as diphtheria because when these patients present to us, we don't have the PCR. We don't have the culture results because they're fresh from the community, and those results can take anything from 24 hours to 72 hours. And we decided to treat this patient for diphtheria, and incidentally, the culture result and PCR came back as Corynebacterium diphtheria, but she also had a group A streptococcus. So this is a patient that had dual infection over here. Here is another case of a patient. Again, one can see this marked edema over the area. You can see bilateral disease, but obviously more pronounced on this side over here. It is not that typical gray looking membrane, but this is an early membrane which is forming. And this again came back as a Corynebacterium diphtheria. And we gave her azithromycin, and we noticed that within 5 days, this membrane was markedly smaller and the patient's symptoms had improved. And just to let you know, these cases of diphtheria, all of them received diphtheria antitoxin with the azithromycin. Now, this brings me to my next point. Not every membrane, not every pseudomembrane, not every upper respiratory tract infection is diphtheria. And this is a differential of a membrane that can be found in a patient's pharynx. And by far the most common cases are group A streptococci that we've seen, Neisseria gonorrhea, Vincent's angina, Staphylococcus aureus, Haemophilus influenza. There's our syphilis as our friend over there. Fungal. In South Africa, unfortunately, we have quite a high prevalence of HIV, and we see Candida all the time. Viral infections, you've got to think of Epstein-Barr virus, adenovirus, herpes simplex virus, and very uncommon causes can be rhinovirus, RSV, coronavirus, and CMV. I have a colleague of mine rather saw a case of a patient with COVID-19 with a membrane. In saying that, with the pandemic, which we had a few years ago, I had not ever seen one membrane. So I do feel that COVID is a very uncommon cause of a membrane over the tonsillar regions. And then non-infectious causes, you must be concerned of patients that have agranulocytosis, leukemia, aphthous ulcers, and traumatic ulcers. Now, I'm going to give you a case scenario, and we're going to visit the patient that I had initially shown. So this was the first person I showed you. And what did we do for him? So we did an ECG, which I will show you in the next slide, which I highly recommend that every patient gets if possible. We did a full blood count, kidney function test, and incidentally, this poor gentleman also had acute kidney injury. We also did urine dipsticks, which were abnormal. We swabbed his throat for MCNS, microscopy, culture and sensitivity, and the diphtheria PCR, and they all came back showing diphtheria. But obviously, we didn't have those results at that time, and we decided to give him 80,000 units of diphtheria antitoxin, as well as azithromycin. And importantly, in our circumstance, we do get consent from our patients because of the risk of anaphylaxis. It is only around 3%, but it is still important to get it done. We do give the diphtheria antitoxin in our high care unit, or at least in a unit which has cardiac monitoring, and we ensure that our patients are next to a resuscitation trolley in case they develop this anaphylaxis. And I cannot stress how important it is that we notify these patients. My colleague Arifa Parker did allude to this, and it's so important because what we do in South Africa is, once we identify a person has got a diphtheria, we will then go and do contact tracing to find other people or other contacts of the patient who may have been exposed to diphtheria, and therefore try and give them prophylaxis, vaccination, swab, etc., etc. Now, as I showed earlier, for that gentleman, we did an ECG for him, and for those that don't look at ECGs regularly, I'm sure it's quite easy to see that this is not a normal looking ECG in a young gentleman. And this poor gentleman actually had a complete heart block with an associated kidney injury, and unfortunately passed away a few days later, despite getting diphtheria antitoxin as well as azithromycin. And the reason I suspect is this was one of the first cases that we dealt with diphtheria, and we weren't very aware of diphtheria in South Africa at this point, or at our hospitals. And I think there was a delayed diagnosis and presentation of this patient to our facility, and unfortunately he passed away. I wanted to show you what are the antibiotics we give. So azithromycin is our first line agent, and this alludes to what Jamie had mentioned earlier, in that we have noticed that our isolates are penicillin intermediate or penicillin resistant, and therefore we have opted to rather go down the azithromycin route for all these patients. We now give 7 to 10 days. You will find other guidance suggesting 14 days. So just follow what the WHO says, and what your hospital has. And Jamie alluded to this as well earlier about the Bez-Redka protocol and the pre-medication. We did do this in the beginning, where we made sure that patients didn't develop an anaphylactic reaction, they weren't allergic to the medication, etc. We have now gone away from this, and this is because of the risk of delaying and not giving patients that. And as I mentioned earlier, that the risk of anaphylaxis from diphtheria antitoxin is only around 3%, and hence the need to have your crash trolley, your resuscitation trolley next to you in cases where the patient does develop an anaphylactic reaction. And then this was already shown earlier. We decided to go for more than for 80,000 units of diphtheria antitoxin because our patient was delayed presentation of more than 48 hours. He also had severe disease. He had acute kidney injury as well as a complete heart block. Other management considerations, and this is not particularly to the patient, which I've already spoken about. We do alternate day ECGs because the risk of myocarditis is generally the highest in the first 2 weeks of illness. And we, as Arifa alluded to, we swab patients on day 3 and day 5. And that's because we also struggle to keep patients in isolation facilities for 14 days, especially when you have more than one patient presenting at a time. And it's not to say that we don't have isolation facilities. I work in a busy tertiary hospital, and our problems are that we don't have enough beds where patients remain in our emergency units for long periods of time before they get moved to wards. So hence the need to try and de-isolate these patients as soon as possible. And one of the other things to consider is also doing vaccination post-infection. What am I saying? A patient with diphtheria does not have enough natural immunity to overcome them getting diphtheria again. So hence it's important that they receive their vaccination again. And then follow up we do at 1 and 3 months. And that's to look for any complications of myocarditis or neurological. And then once again, I've added in over here because I cannot stress it enough. It is so important that these patients are notified to your health authorities. I'm going to get into our next case. This is much quicker. Again, a patient with a sore throat, pseudomembrane. I'm not going to show it to you. You've seen enough cases, but you can see this gentleman had a bull neck over here, very large lymph node on this area. Luckily, he did not require intubation. He got diphtheria antitoxin very quickly. He received 80,000 units and did pretty well. But I do want to mention what are the red flags for upper airway obstruction. Patients with noisy breathing, drooling, limited mouth opening, a plummy voice or hoarseness, unable to lie flat, a bull neck. These are the patients where you need to get ENT as soon as possible. Please don't rely on oxygen saturations. It is not a good marker of upper airway obstruction. Once your oxygen saturations go down, your patient is in big trouble. You're going to be intubating that patient then and there. So what are my take-home messages? As I alluded to get the PCR, to get the MCNS takes anything from 24 to 72 hours. Therefore, it is so important that you recognize what is a pseudomembrane, what is the possibility that this is diphtheria, and then treat it based on the clinical circumstances that are presenting to you. Furthermore, it is imperative that you have enough stock of diphtheria antitoxin. And in these cases, what we've done is we've tried to distribute our diphtheria antitoxin so that it's not only at our tertiary facilities, but that it is also at our secondary level hospitals, so that the diphtheria antitoxin can be given then and there at the patient bedside. And then it's so important that you understand your susceptibility data. I've already mentioned that azithromycin is our go-to drug. We rarely ever use penicillin nowadays for our patients. And with that, I'm going to end. And once again, thank you very much for listening and for inviting me to give this presentation.
Thank you very much, Dr. Tahi. We have heard you very loud and clear. Very brilliant presentation. Thank you. And I am sure colleagues, especially our clinicians, are also on the call, and they've heard you loud and clear. Quite interesting differentials. But then as clinicians, we must use our golden rules of treating cases, one of which is history, followed by examination. We should not rely on labs. In some of those settings, laboratory facilities are not even available. So we must heighten our clinical index of suspicion, assess your patient, and come up with a differential whilst you're waiting for your definitive diagnosis. We also take note of the Bessel protocol. I think that will be adopted also by our colleagues when they're using the DAT. So to summarize, all what we have had with regards to clinical care and the IPC for clinical care, you must not rely on laboratory. Immediately you suspect your patient, isolate and commence treatment. Treatment should be guided by or could be guided by the WHO's recommendation using macrolides, but then also look at your susceptibility pattern in your local setting. And also with DAT, when you're using DAT, there could be risk of side effects. Ensure that you have all of the medications to counteract the side effects when you are using DAT. For IPC, isolate your cases, use contact and droplet infection precautions as required. And we also noted the use of vaccines and prophylaxis for contact and high risk. The slides will be shared and would have detailed information when we go over the slides. Thank you very much. We'll now open the floor for questioning. Let's see if we have any questions in the Q&A. Okay, so the first question we have is many thanks to all the presenters. This is from Danjuma Abdulrahman. Any insight on poor exposure prophylaxis for caregivers and healthcare providers? There is also one in French. It is on disinfection. I think that would also be for either Dr. Parker or Madison. We also have one with regards to vaccines. It reads also similar concern with regards to TB vaccine. In most cases, the available doses are coming about from maternal and childhood programs. So I don't know whether this is referring to the availability of vaccines. May I kindly request that the interpreter, the French interpreter, reads out the French questions for us, please. All right, thank you very much. Okay, participants, colleagues on the call, my apologies. I have read on the chat that the Bessel protocol is no longer recommended. So please take note of that. So let me hand over to our panelists. I think we'll start with Dr. Madison and also Dr. Parker on the IPC questions.
Thanks so much, Rashidatu. So this is the questions were whether or not caregivers are advised to be vaccinated, and as well whether there is any complications between the tuberculosis vaccination and diphtheria. Is that correct?
Yes, yes.
Okay. So from WHO guidance, and of course there's advice regarding vaccination of persons within the community that are experiencing diphtheria outbreaks, as well from our end in the IPC world for vaccination of health and care workers. We don't specifically within WHO guidance have any particular text which prioritizes the vaccination of caregivers. But of course, if the vaccine is available, just like we recommend for family members that are in households caring for patients with diphtheria, we would advise that it as available and when available, this would be advised that the caregivers get vaccinated. For any contradictions between the vaccines, I'm not sure. So we'll pass to Dr. Parker if she's aware of any contraindications there, but from my end, I'm not sure. Over from me.
Okay, thank you. Dr. Parker, do you have any addition to this? In fact, there is a question for you. It's written in French, but I think we've had it.
Mm-hmm.
How do you cycle waste, I think?
No. So the first part of the question in terms of caregivers, so our policy based on WHO guidance and our National Institute for Communicable Disease guidelines is that all contacts would be screened and given prophylaxis, which would include prophylactic antibiotics. So in our setting, we would use azithromycin. Still recommended at 7 days, but I do think a shorter duration might actually be okay. And this would apply to caregivers, anyone who is in contact with the infectious patient. We would also use the opportunity to vaccinate. So at the moment, we practice ring vaccination from a public health approach, where we try to vaccinate widely around the cases. And then while I'm talking about vaccination, there was a question in French around the South African schedule of vaccination. So currently we are supposed to be giving 6 doses. So at 6 weeks, 10 weeks, and 14 weeks, and then also boosters at 18 months. And also childhood and adolescent boosters at 6 and 12 years. But the uptake is extremely poor with the 6-year and the 12-year-old boosters. Adult vaccination is not part of policy, but that is being discussed, and we are encouraging at least healthcare worker vaccination. So from the Russian or Soviet Union outbreak in the past, many, many, many years ago, I think the lessons that we learned was that in addition to improving childhood vaccination, we're going to have to also improve adolescent and potentially some pragmatic targeted adult boosting strategies. And then I think the question was around cleaning or equipment. So diphtheria, Madison mentioned that the organism is easily killed with what we routinely do in our practices in terms of cleaning steps, soap and water and disinfection with either alcohol, hypochlorite solutions, and so on. So that is what we use in our setting. Waste, it's not like what we would do with a suspected viral hemorrhagic fever patient where we would incinerate, everything. It's actually disposed of in healthcare waste that we would routinely do because we have systems in place for patients who have infections that could be transmitted through contact or droplet spread. So that's what we have been doing at our facility. So like Madison mentioned, it's important to have your standard precautions and systems in place, because that also eliminates or somewhat eliminates risk. Thanks.
All
Did I
right.
miss questions? I think that was what I remembered. Thanks.
Yeah, I think I'm also looking at the Q&A. I think that is what we have for now. We'll move over to our colleagues for clinical care, Dr. Tari and Jamie. I don't know if we still have Jamie on the call, but there is a very interesting question. I think I would like to start with that for Dr. Tari. It reads, how beneficial is random blood sugar monitoring during DAT therapy? There are increasing observations, possibly unpublished, of high risk of low blood glucose among diphtheria cases during DAT. Any experience from South Africa or elsewhere? We have heard about the risk of myocarditis, so we also want to hear about hypoglycemia. Thank you very much, and over to you, Dr. Tari.
Thanks. To be honest with you, I haven't read or heard of any problems with glucose monitoring in patients that have diphtheria and are on diphtheria antitoxin. Obviously, the diabetic, the type 1, etc., that might be an issue. But specifically as a side effect of diphtheria antitoxin, I'm not aware of. And then, sorry, what was your second question again?
Okay. So there's another.
Oh, the myocarditis.
Yes.
Yeah, sorry, the myocarditis. Okay, so the myocarditis, we don't see it very often. I've seen two cases. The one I've already mentioned, and then the other case was a patient where they presented with what looked like a myocardial infarction. But when we actually look back, it was probably a myocarditis, and he did okay in a sense. He was a rather interesting gentleman. So he got diphtheria. A month later, he presented with a myocardial infarction, which was actually myocarditis. And then 2 months after that, he presented with what looked like a Guillain-Barré syndrome. So he had severe neurological fallout from his diphtheria. So it is uncommon, but we do see it. And the whole point is that you need to give diphtheria antitoxin as soon as possible. The longer you wait, the higher your risk of the toxin entering into the cells. And the problem is, once the toxin has entered into the cells, giving diphtheria antitoxin is of no use. It needs to mop up the free toxin, it won't mop up bound toxin. Thanks.
Okay, thank you. We have 2 additional questions for you. The first one reads, for how many days should a child of 5 years take azithromycin and the dosage? The second one reads, when DAT is not available, what do we do? Over to you, doctor.
Sure. Okay, thanks. I'm going to put a caveat here. I'm an adult physician, and I haven't treated kids in 15, 16 years. But I think it's pretty similar with regards to the dosage. The dose is 12 milligrams per kg once daily, to a maximum of 500 milligrams, and you treat those children for 7 to 10 days. Yeah, and then what do you do when you don't have diphtheria antitoxin? Sure. That's really difficult, because as Arifa has alluded to with her case, which had a negative outcome because they didn't have access to diphtheria antitoxin. It's a problem, right? What could I advise in that case is you just give azithromycin as soon as possible, and just monitor that patient as carefully as possible, and try and ensure that you get diphtheria antitoxin for the next time. I'm not aware of any other treatment other than diphtheria antitoxin that will help with toxin mop-up. Arif, I see your hand.
Yes,
Hi,
please.
so
Over.
no, I just wanted to add to what Tari was saying. I neglected to mention for that case, which was managed by Professor Helena Rabi, she gave polygam while we were trying to wait for the antitoxin, hoping that we would get some antibodies to the child. Thanks.
Yes, Jamie, do you want to add?
Yes, thank you. It won't help the clinicians, but it may help future patients. That if you find you have patients with diphtheria and you have no access to antitoxin, then you really should, as the South Africa team did originally, raise it with the WHO country office, and we will do all that we can to try and make that available. Clearly, our resources are a little bit limited, but we both advocate and support the provision of that for all patients with diphtheria. And please do let us know if you have patients and do not have access. It's really important. It's life-saving. Thank you.
Thank you, Jamie. Just to add my voice to that, we had sent out the DAT quest templates to the countries in response, and we're waiting for them to resend these templates so that we can see how best to secure DAT for the countries. So we are coming to the end of this very educative webinar. I'm sure you'd all agree with me that we have learned something from our colleagues on the call. Would like to start by thanking our exceptional presenters today. Thank you very much for your insightful presentations. We have learned a whole lot from you. We also want to thank you, the participants who sat throughout with us. I know we are definitely glued to our seats, so we learned a whole lot, and it is very good that we will be taking home these very critical and useful messages. I would also like to thank our organizers, that is the training team, Amarachi, and our ECHO colleagues. Thank you very much for the support that you have given to us. I would not end without thanking the IMST for putting this together. As I had said earlier, this will be a series of webinars. We'll be talking about vaccines. We'll be talking about risk communication alongside our teams in the IMST, our colleagues are in the IMST. So I want to appreciate you all. Thank you very much, and stay tuned for our next webinar session. Once again, congratulations to the panelists. You have an enjoyable rest of the day. Thank you.
Thanks, everyone.
Thank you all.
Thank you, colleagues. Please take some time to fill out the survey, the post-session survey in the chat. We're pasting the link below. We're anticipating your responses and thank you in advance.